the human body actually cannot violate any of the scientific principles of the universe in general, and that includes all of the non-living elements of the universe. So if gases or liquids behave in a certain way, then the body has to find a way of using a gas or a liquid in that manner. And so the next section of this PowerPoint really deals with some of the principles behind gases. And there's a couple of facts you got to put in your mind. The first one is right here. Gas pressure and volume are inversely related. I tried to relate that to a pump or to two chambers before. What gas pressure relates to is a chamber size and the gas molecules within it. These are in motion and they're bouncing off the walls. Now, they have a certain energy, and as they bounce, we measure that kind of collective energy of this picture by that gauge called gas pressure. Now, I know a couple of ways I can increase this gas pressure. I can put more molecules, and if I double the number of molecules, then I get twice as many collisions, and the pressure goes up. If I increase the energy of each molecule, so if I heat this chamber, that actually causes the kinetic energy of each molecule to increase. So it hits the wall harder, and the pressure goes up. But I can achieve it in another way. And this is what's germane to our body and how the respiratory system works. And that is that we move our lungs. We actually move the chamber. So what we see here is going from a larger space to a smaller space, in this case pushing down. That actually increases the density of the molecules. So twice as many collisions, and the pressure goes up. So these are all just manifestations of this basic relationship. Gas pressure and volume are inversely related. Less volume means more pressure. Also, if you heat, it means more collisions. That is also, by the way, a feature that we use for air conditioning. If we compress something, it heats, and it heats the pump. This is one of the ways that a heat pump works. You compress the gas that's in that system, and that side gets hot. You basically blow air past those pipes and you're heating. When you release the pressure, squirting it out through a venturi, that part of the pipe gets cold. And so now you can blow hot air through there to remove the heat. Basically back to this same, pressure and volume are inversely related. The more volume, the less pressure. Increase the volume, and the number of collisions per square unit area, which is what pressure is, goes down. Also, if you cool it, you decrease the energy, it also cools down. So back to our model of the lung, and a basic relationship. We're at equilibrium. We're walking, not at equilibrium, but we're walking around at the bottom of an ocean of air. The surface of the earth represents the bottom of our gas column, the atmosphere. The pressure that we encounter every day, atmospheric pressure, 760 millimeters or 30 inches of mercury pressure, is a result of how much air is on top of us. Likewise, if you change your altitude, if you go to the top of mountains or you fly in an airplane, there's less gas on top of you, so the atmospheric pressure drops. But we're operating our respiratory system relative to that. So if I'm going to start with the standard temperature and pressure assumption, and at sea level, at typically 20 degrees centigrade, a standard temperature, at sea level, the pressure would be 760 millimeters or 30 inches. Now, if I am holding my lungs still with my airway open, that means the pressure inside my lungs is 760. If I do something with my muscles to move the lungs and increase the volume, the pressure drops. Volume up, pressure down. The lower pressure in the lungs means that 760 millimeters can now push air. Pressure basically goes from high pressure to low pressure. So high pressure outside to low pressure inside forces air into the lungs. I don't have a pointer yet. Forces air into the lungs. Now, when the lungs are full, they've expanded as much as they can, and I release that muscle pressure to inflate. A couple of things happen at rest. We've talked about the return of the diaphragm and the contraction of the lungs by elastic rebound. So a slight movement of those motive elements applies a pressure to these lungs. So maybe the pressure here goes from 760 up to 820. Now 820 inside, 760 outside, and air flows out from high pressure to low pressure. This kind of simple principle explains how we approach understanding lung function, diagnosing problems, and some of the problems we encounter in their treatment. We talk about the compliance of lungs, which really is a measure of the ease with which the lungs and thorax expand. Now, that sounds like a very positive thing. You would think you would like it to be as easy as possible to fill the lungs, but it turns out that's not the case. Just like with the heart, if you have an enlarged heart, a bigger, more muscular heart, then you can move more blood. But you get that enlarged heart by overworking it. There's a kind of a homeostatic happy zone for heart function. The same is true with the lungs. So if you have an example, for example, you compromise the elastic tissue in the lungs due to emphysema, then compliance goes up. It's actually easier to fill the lungs, but it's more difficult to empty them. High compliance. If you have low compliance, then it's harder to expand the lung. You get this in instances where alveoli or lobes of the lung collapse, respiratory distress. You can get them if you obstruct an airway so that there's some flow problem in the same way we saw with the heart. Sometimes we had to deal with an arterial blockage. What happens if we have to deal with a bronchus or a tracheal blockage? If tissue becomes hardened, so you lose elasticity, then it naturally does not move back and forth so readily. And with advanced age, fibrosis is something that we see in basically all tissues of the body. Finally, if your joints don't move, and arthritis it accumulates with old age, the joints become stiffer, joints become less mobile. I know that a common feature of old age for me is that in the morning I wake up and I'm in bed. I usually am experiencing joint pain, but am fairly comfortable. But I begin my day by sitting and lying in bed and doing this, just to increase the circulation with my hand and begin stretching those ligaments and muscles and tendons to get the joints warmed up so they're moving. Now, as it affects the joints that surround the thorax, and here we're talking about the vertebrocostal joints and the sternocostal joints as the main connections for the ribs, it can affect compliance. When we measure respiratory volumes, this is a good picture of a respiratory therapist applying good technique. Lung volumes are measured with a spirometer, and we use a combination of air and water and standard temperature and pressure. Now, this generates an electrical signal through the spirometer and causes a needle to wiggle up and down. When you put a drum on it, it forms these peaks and valleys. This tracing can then be used as a permanent record. We now do this more or less digitally and record the data in a different way so we can look at the numbers. This is called a spirometer. Good technique, pardon me, is shown here with a patient, their mouth completely enclosing the mouthpiece of the air tube and their nose completely blocked off. Now, the reason this is true is that you can control, to some extent, the flow of air through your nasal passage, but this is such a common pharynx that you can't control it completely. So for best results, you need to block off that escape air. All the air that's moving needs to move through the tube. Now, what's shown here is a sort of an idealized and condensed version of a spirometry tracing. In science, when you use an instrument, you always have to worry about things like calibration, things like drift, things like standardization. And so it isn't as pretty as this picture in real life. But one of the things the scientists can rely on is the standardization by repetition. If you set a breathing patient up, as just shown, and they breathe and it produces the same tracing in a level manner over time, then you call that a baseline. Now, if that is if that is sloping upward, in other words, it's a straight line that's basically sloped up or sloped down, then some kind of effect in the instrument is changing your readings. But if you standardize your approach, this is something that you can correct for. So what is shown here are two peaks of a spirometry tracing. This is called the resting tidal volume. Now, any steady breathing state would be called a tidal volume. Tidal volume at rest gives you a kind of an idea of air exchange or volume exchange at standard temperature and pressure. About a half a liter is the tidal volume shown here. Now, the volume in milliliters of air at standard temperature and pressure is shown on the vertical axis, and the lower axis is just time. So when you're setting a patient up, you would actually allow them to continue to breathe and rest until you had a nice long line of these tidal volume peaks and valleys. As the line rises, you are inhaling. As it falls, you are exhaling. And what's represented on this tracing is everything from 0 volume all the way up to some maximum that includes your maximum gas exchange. Now, I'm going to try to illustrate the changes and the portions of this breathing cycle and name them. And then we'll talk about averages for normal males and females. So if you, at this point, instruct the patient to complete their next exhale, this point right here, and then push actively all of the air out of your lungs, evacuate your lungs totally. If you need to bend over to get that last little bit of air out, then do so. Now, this produces this dip called the expiratory reserve. Notice the reserve is below the resting tidal volume. Now, after this, we've returned to one resting tidal volume cycle. So this is the expiratory reserve. Now you're going to advise the opposite. At the next peak, after you've inhaled at rest, I want you to completely fill your lungs to its maximum capacity. So breathe, lift your rib cage, lean back, do whatever you want to take the deepest breath that you can. That produces the inspiratory reserve on top of this tidal volume kind of middle space. So from here to here would be the inspiratory reserve. Notice that it's above the tidal volume. Now, rather than returning to at rest, the next thing to illustrate is from this peak, and that is to instruct a patient at the maximum inflation point of the inspiratory reserve. I want you to breathe out and expel all the air you can. Now that produces what's called the vital capacity. All the air you can breathe in to all the air you can push out. That's called the vital capacity. Also notice that on the inspiratory side, if you include the tidal volume at rest, that's called the inspiratory capacity. Now, so vital capacity is actually a real measure of how much you can breathe in and out. And you'll notice that what we've done over on this side is just return to total volume, tidal volume at rest and normal breathing. When you do this, you'll notice a couple of things. I want to first point out the residual volume that's shown here at the bottom. We basically have a residual volume and a minimal volume of lung capacity. That means that in this 30 to 120 mil range, in this range, we have a positive volume still left in the lungs. That means, think about breathing in and out. When you're at your bottom of your breath, right here, your maximum expiration. At that point, you've still got this volume in your lungs of expired or depleted air. So when you breathe in, that fresh air is not at the air, is at the concentrations of the atmosphere, 20% oxygen, 21% oxygen. But as it comes down, it's mixing with this depleted air. So the air pressure in the lungs is actually lower than the atmospheric pressure. So that leads us to the chart where we see males and females, based largely on their difference in body size, have different overall capacity. So vital capacity, inspiratory reserve of 3,300 and 1,900, basically a resting tidal volume of about half a liter, and expiratory reserve of about 1,700. The residual volume, look at that, 1.2 liters in a male, 1.1 liter in a female. As I say, these differences are based largely on body size, and males on average are larger, so they have about a 6 liter pulmonary capacity and 4.2 liters for females. Respiratory volumes can be important in other ways. So for example, let's say I take a vital capacity reading. I can get to total volume, but it takes me a long time to inhale. So you perform a different test called a forced expiratory volume. This is how much air can be moved, exhaled, in 1 second. This can indicate that the problem is not a lung capacity or a lung congestion problem, but an obstruction. If you have a small point in your airway and you're having to work hard to draw air past that point, however, you do have the flexibility, the elasticity in your lungs to expand up to a normal volume, then the FEV1 will reveal that. The residual volume leads to the idea of different spaces. Here's the inspiratory reserve shown as this big blue moon shape, the tidal volume shown in white, and the expiratory reserve volume shown in light green. The residual volume is shown in dark green. So the total lung capacity, shown here, is reduced by this residual volume. The vital capacity is shown here as the total of these. Now, what would anatomical dead space include? When you finish a breath, the trachea and the bronchi are still full of lungs. There is a residual volume in the lungs as well. But it's anatomical dead space because no exchange is going on in bronchi or bronchioles or trachea. So that anatomy reduces the efficiency of oxygen in, The physiological dead space would include alveoli where there is no gas exchange. So the anatomical dead space is shown above this diagram. The physiological dead space would be occurring within it. Respiratory minute volume is the air volume moved in a minute. And typically we begin by saying, well, what is your resting tidal volume? If it's 500 mils as a resting tidal volume average, and your breathing rate is 12 breaths per minute, then quite simply, your 12 times 500 would be 6,000. For a respiratory minute volume. However, the actual oxygen delivery is going to be affected by that dead space. So breaths per minute, we're going to take the tidal volume, but we're going to reduce it by the dead space. So as an example, here's 12 breaths times 500 minus 150, a substantial volume, brings the actual alveolar ventilation. What's moving in and out of the alveolus and is available for external respiration, 4.2 mils. Alveolar ventilation also is affected by the level of exertion that you're experiencing. How hard are you working? So using this same formula, when you exercise, and what if exercise changes the value from 12 breaths per minute to 24? That would be pretty light exercise. But the tidal volume would go up to 4 liters as you breathe quicker and more deeply. And you also, as you expand the lungs, you're expanding the system, you're expanding the dead space. So what does that mean in terms of alveolar ventilation? Under these conditions, which are not by any means a level of maximum exertion or average maximum exertion, we'll notice 24 breaths a minute times 4,000 minus 300 comes to 88.8 liters per minute. So we've gone at rest from 4.2 to 88. So it basically increases our alveolar ventilation over 20 times. In the same way, we saw that we had an at-rest configuration for the heart, and then we had a reverse capacity. We made the statement that an average person could increase their cardiac output 3 to 5 times, and that a superbly conditioned elite athlete could increase that cardiac output between rest and exertion 7 times. What we see is a tremendous range of ventilation possibilities in the average person. So when we're exerting ourselves under meeting these conditions, we can increase our ventilation of alveoli by 20 times. Gas exchange, that's what the respiratory system does. We're going to use oxygen and make carbon dioxide at the cellular level. I always flinch when you ask me something like, what's the most important molecule? Well, you need a criterion, and my criterion is what do you die quickest without, and that's oxygen. If you're trying to starve me to death and I'm trying to strangle you, I'm going to win that fight. The constant waste product that goes up and down with the consumption of oxygen is carbon dioxide. And I want to point this out. When we talk about consumption rates, ATP production, it's going to be correlated with our breathing rate. It's going to be correlated with our oxygen exchange. Another law looks at, when we think about the ventilation in our lungs on a basic level, we're going to have to think about what is air and how much oxygen does it contain. So we're not dealing with pure oxygen, we're dealing with a mixture, because that's what we find in our environment. Our environment now is between 20 and 21% oxygen, although estimates from past historical times indicate that that's a variable amount. There have been estimates as high as 26 and 27% oxygen in the Earth's atmosphere that related to the position of the continents, the amount of land available to grow land plants and contribute to higher oxygen levels as a result of photosynthesis, etc. But we have to understand what is the oxygen's role in our atmosphere. The gas crosses the respiratory membrane by diffusion. The arriving red blood cells and blood into the capillary bed is enriched in oxygen. The tissues that surround them are consuming oxygen, so there's always high concentration in the arriving blood, low concentration in the tissues, and diffusion moves oxygen right over. Now, however, although we're interested in the oxygen, it's accompanied by close to 80% nitrogen gas. It turns out Dalton's law says that each gas operates independently of the others in the mixture. So if you have a mixture of a lot of gases, the percent fraction of each gas will allow you to estimate the pressure contribution of that gas. That's called the partial pressure. And we see it illustrated here. We have similar volumes and similar measuring in this system. And we have set up 3 individual gas samples that are identical to the gas complement in the mixture. So if you see 8 blues over here and a certain volume, then you should see 8 blues in this mixture. And this shows you that the total pressure of the contribution is the same in the mixture as is present in the single particular sample. So red, green, and blue add up to this pressure from the addition of these 3 individual measurements. This is called the partial pressure of the gas, and it gives us a ready clue. In this set of slides, we estimated 20.9% as the percentage of oxygen. 760 millimeters of mercury means that we are having a partial pressure of oxygen of 159 millimeters of mercury. Now that affects the external respiration. The second thing that affects it is when the gaseous oxygen arrives at the respiratory membrane, it doesn't go through as a gas. It actually has to dissolve in the surface, surfactant and mucus and liquid coating. That means that each gas is going to be limited by its solubility. If it's really soluble in water, then it's going to jump into solution. If it's limited in its solubility, then it's going to dissolve into water at a slower rate. And this is called Henry's law, basically showing you an example that's kind of set up to explain how gas solubility works. Here's a sample. You'll notice gas molecules in the gaseous phase and a beaker of water showing that some molecules are dissolving in and evaporating out, basically. And in the liquid phase, you'll notice a much lower concentration. The concentration is sort of estimated by how close the dots are together. You notice there's a lot of dots out here, but not many dots in here. This would mean a low solubility. And this kind of test and the physical measurement of the solubility is going to affect how the different gases behave in our body. In the air and in the blood, 78%. Now we have a little bit different estimates here. 78% nitrogen is shown as the partial pressure in nitrogen. Let me just comment on that, because we need nitrogen, right? It's one of our big 4 elements. But one of the ironies is every time we take a breath, 78% of the air is N2, And every time we breathe out, every bit of that N2 goes right back out of the body. It's bound together so tightly by a triple bond that our body can't take that nitrogen apart. It's inert. So although it's contributing to the gas pressure and the air proportions, the partial pressures, it's not something where we can harvest nitrogen. We have to get nitrogen from the proteins we eat. 21% oxygen is shown here. And then this 1% that's left is very interesting because it contains all the other gases that we find in the air. And those are many, but they are all in low concentration. The one that's most important to us is carbon dioxide. And that's because we're making and exhaling carbon dioxide gas. It's 0.03% in this estimate. Not 3%, but 0.03%. So you can see we're going to have to get to fusion, we're going to have to dip below 21%. To get elimination, we're going to have to go above 1%. However, there's a big difference. Oxygen is much less soluble than carbon dioxide in water. And so the partial pressure in oxygen in the alveoli is going to be 100 millimeters of mercury because it's reduced by its limited solubility. Whereas the partial pressure of CO2 in oxygen, compare this, look at this, 0.2 millimeters comes from its proportion of 0.03%, but it goes up to 40 millimeters of mercury as a result of its incredible solubility. That's because CO2 is much more soluble than oxygen. This is not a new principle. We're returning to it. We noticed that carrying CO2 back from the tissues in the cardiovascular system was very straightforward. So in kind of looking at these values, these are the kind of values we deal with in looking at oxygen and CO2 levels in the body. And think about now external respiration. In the alveolus here and the capillary here, we're seeing arriving blood. It's blue in color because it's depleted, with a partial pressure of oxygen of about 40 millimeters and a partial pressure of CO2 of about 45, right next to a gas space where the partial pressure of oxygen is 100 and the partial pressure of CO2 is about 40. So diffusion is always high to low. So oxygen's going to go this way, CO2 is going to go this way. And by the time we cross the capillary bed, the partial pressure of oxygen is up at 100, and the partial pressure of CO2 has been lowered to 40. We're going to expect the opposite movement when we get out here to any tissue. And by the way, what's illustrated in this diagram is actually going on in capillary beds all over the body. As this enriched blood arrives in the capillary bed, the partial pressure of oxygen has been diminished a little bit by the flow through the system. Oxygen is absorbed by the cells and is lost. But an arriving partial pressure of oxygen of 95 is going to be opposed against a partial pressure of 40. So diffusion is going to drive oxygen out. And the CO2 that's produced of 45 is going to be balanced against a carbon dioxide content of 40, so CO2 is going to be extracted from the tissues and put into the blood. And so you can see the depletion of oxygen and the enrichment of CO2 as we flow through the systemic system. Now, expired air is actually very different than the air we breathe in. If you think about the air we breathe in is 21% oxygen, the air we breathe out is going to be considerably lessened. But the real change is in the CO2. The air we breathe in is 0.03%, but the CO2 enrichment of the air we breathe out, what's coming back out of our lungs, is considerably higher than that. And so we're really an organism, as every organism on Earth that uses oxygen is going to make CO2. And that's going to contribute to the CO2 in the atmosphere. But diffusion is never going to resist that release of CO2 to any appreciable extent. Oxygen transport we've covered, and let's return and just summarize the points. We saw this in the cardiovascular system. Oxygen transport has one main carrier, and that's hemoglobin. A tetramer, two alpha and two beta chains formed around a heme group. We never did draw heme up. Here's the iron molecule. And you'll notice the attachment to 4 nitrogens, and those nitrogens attached to a big carbon network called a porphyrin ring. This is the heme group, and this is where the oxygen binds, right here. So 99% of oxygen transport is due to the hemoglobin. Very, very little is transported by plasma. It shows the limit of solubility of oxygen inside the water base of the plasma. However, you're not limited to the body when you think about hemoglobin. When you look at hemoglobin, it's a protein. You can study it in the lab. So let's take a sample of hemoglobin and put it in the lab under different partial pressures of oxygen and ask the question, how much of the hemoglobin in the sample is saturated? Now, this is going to allow us to explain some secondary effects of blood and its ideal relationship to hemoglobin and oxygen. The oxygen hemoglobin saturation curve is something you can measure independent of a body. This is the percent of saturation by the hemoglobin. So since each hemoglobin molecule has 4 sites, 25% right here would mean that each molecule on average is carrying 1 oxygen. 50% would mean you're carrying 2. 75% would mean you're carrying 3. And notice that 3 out of 4 sites saturated occurs at a relatively low partial pressure of oxygen. In the lungs, we saw pressures up here at 100. So 4 oxygens per hemoglobin molecule would be along this line. And you'll notice it never reaches 100%. What happens is at low partial pressures, you get automatic binding and carrying all the way up to this break point. And then it starts to lessen in its binding facility. Up here above 75, everybody's carrying 3 molecules of oxygen. And most are carrying 4, but as you get up into these reaches up where the pointer is now, that 4th one is popping off and preventing the full saturation. Now, we've seen this with carbon molecules before, is that there's a saturation curve and not an absolute just straight line up to 4 molecules. So you can notice through these partial pressures, there are tremendous jumps through this mid-range and all the way past the realistic partial pressures of oxygen we have in the human body. So it's very, very easy, given our atmosphere and our lungs, to get up into this range of saturation for oxygen. So let's compare this a little. This is just basically trying to show you how exercise affects oxygen transport of hemoglobin. And the way we're going to start is right here with the partial pressure of oxygen in the lungs, which is registered here at above 100, but basically between 100 and 105. At that partial pressure, you're up here around 98% saturation. So you're carrying a lot of oxygen out of the lungs. When you get to the tissues at rest, you're going to find a partial pressure of oxygen of about 40. And at that point, the hemoglobin would naturally be about 75% saturated. Now, we're not talking here about burning ATP or anything. We're just talking about exposing it to oxygen. So what this is showing you is at rest, there's an automatic release from, I guess they're calling this 98 or 97, from 98% down to 75% is a release of about 23% of the oxygen. Now, this oxygen tissue value is going to be sensitive to your level of exertion. At rest, it's relatively high in the tissues because you're not burning oxygen very fast. You go into the capillary bed, it automatically dumps 23% of the oxygen, and you're happy. However, when you start exercising, in the lungs, we're still delivering about 100 millimeters and getting about that 98% saturation. But now, the consumption in the tissues, and especially around the blood around muscles, the partial pressure has dropped from 40 all the way down to what looks like about 15. Now, hemoglobin is only 25% saturated. So, as you go into these capillaries under exercise, the hemoglobin automatically releases almost 3 of those molecules just based on the kinetics of the hemoglobin saturation curve. So under exercise, when you start exercising, the hemoglobin releases its oxygen at a higher rate and delivers more oxygen to those needy tissues. Oxygen transport is affected by other conditions that accompany our exercise. And I want to remind you of something we talked about with the blood. When we saw CO2 go up, we saw the production of carbonic acid and bicarbonate and the release of hydrogen ion. Hydrogen ion goes up in water solutions, and hydrogen ion going up means pH goes down. So what that means is when we start to exercise, more CO2 is generated, more carbonic acid and more bicarbonate and hydrogen ion, and the pH drops. So one of the things in understanding hemoglobin and its action, we've already shown that the simple act of exercise itself causes hemoglobin to release oxygen at a faster rate. What about the accompanying effects of bicarbonate, of hydrogen ion increase, along with CO2, and pH drop? Now, what that would do is shift this curve to the right. So here is the curve before the shift. But as the pH drops and the CO2 increases and the temperature increases, by the way, that's another factor when we exercise, our heat is generated and our temperature goes up. So what happens is called the Bohr effect. It shifts this curve under exercise to the right. So when that happens, the saturation, you'll notice, is dropping from about 32% down to about 18%. So there's this additional delivery of oxygen based on the CO2, on the pH and the temperature factors. So in developing an oxygen transport system and developing all the activity we have, which is dependent on that oxygen transport, hemoglobin was the molecule that was ideally suited for picking up that oxygen and getting it to the tissues at the highest rate possible. All of the effects of exercise in our body, including dropping pH and increasing temperature and increasing CO2, contribute to greater delivery of oxygen by the hemoglobin. So we see here just a generalized kinetics curve that is showing the effects of normal, which is blue. We talked about factors shown in purple shifting to the right and increasing oxygen delivery. We can also consider what happens when we go to the left, when we go decrease the CO2 and the hydrogen ion, increase the pH, and decrease the temperature. And what we see is a shift to the left, which increases the retention of oxygen. So it's going to hold on to more oxygen and deliver it. But always, 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 that oxygen demand is driving the system. So a lower oxygen demand will lead to those shifts to the left. Now, that's an excellent place to pause. And so this will be chapter 23B.